first, Carolyn, give her a hand. I'm flattered and surprised and amazed at the work that you are doing and that you've done and the people that you work with and the nurses, maybe the nurses in the room and all that you do, but this could go on for hours. You could tell us so much more. And I think this really, I hope there's questions because I have lots of questions about how you do this and what some of the people we see, have they recovered? Are they getting better? I mean, do they get jobs? I mean, I think you can do a whole other hour telling us about what you do.
Sure. What we're going to do is have Caroline talk a little bit about the movie, and then we're going to have each person on the panel talk a little bit about why they're up here, and then have people ask questions.
Okay, so you saw the 45-minute, and I'm not the only street nurse, right? You know, I just have to keep that in mind, that there was 12 of us at the time, 12 registered nurses, 2 healthcare workers, and our goal was sexually transmitted diseases, HIV, STIs. And we were lucky. We had managers that said, you know what, you go out there, and for sure you're chasing the disease. But often, and as you saw, it was hardly about STIs and HIV. You know, it's about connection, it's about compassion, it's about care, and it's about love. And everybody's got a story, and you know, it is in the downtown east side, and most people are there because of trauma, poverty, etc. But as we know, in many different countries, there's many different reasons why we're addicted. And so I'm not. Yeah, the story, yes, absolutely important, but I want to meet you right there. And I think you can see on the cover of the DVD, many people kind of reflect on that I'm doing blood, but it's the eye to eye, right? And that's so important, and the conversation is so important. And in days where we're all about tasks, right? It's a world of tasks. And we're not having a conversation because we're too busy doing a bloody task, right? And it's not good. It's not good. And this population will turn us upside down, and good. Bring it on, you know? Because ethically and morally, we have a duty to care for everyone. Everyone, no matter what color. Everyone. Right? And we all have stigma. It's not one of us that doesn't have that. And, you know, and this was done just to tackle that and just have a dialogue about it and accept that all of us come with stigma. We can't help what we come with. How do we unwrap it, right? And how do we reflect inside, you know, and change who we are? Because, well, our standards say we can't refuse care, right? Everybody's standards, no matter which country you're in. Says you can't refuse care.
So my name's Pam Lynch, and I'm a volunteer with Harm Reduction Michigan, and I've used Caroline's movie through my work in a lot of different places since it came out in 2007, and I met her in April and said, hey Caroline, how would you like to come to Michigan? Yeah, I was like, how would you like to come to Michigan and help us have an event to recognize International Overdose Awareness Day? So happened to be the week that before she starts teaching for the semester, and so it was wonderful that she was able to do that. And we were happy to be able to speak at the State Health Department, or they invited Caroline to speak at the State Health Department, and then also at the Kent County Opioid Task Force. And in the meantime, because this is a very important event, and because we now live in a world where there is very little street drugs that don't have fentanyl in them, and so we still have a continuing overdose problem. And although we have done a pretty good job changing prescribing and things in the US to change how much new opiate dependency there is, we still have a big problem with addiction, and whether that's alcohol, which we have a lot of in our community, or whether that's people who have switched from opiates to methamphetamine, all of the street drugs have fentanyl in them. You know, we've had people come to the syringe access program and say, you know, I'm a meth user and I'm testing positive for fentanyl. Would they be cutting the meth with fentanyl? Absolutely. They're cutting everything with fentanyl now, just about. So, long story short, the work that we're all doing continues to be important. And I had asked Kelly to come tonight and talk a little bit about his experience as a family member in this community, and a nurse as well, right?
Yeah. My name's Kelly. I heard about harm reduction through a coworker whose son is struggling with heroin addiction, has been in and out of jail, in and out of the hospital. And she knows me as a person in recovery. I've been clean and sober next month, 38 years. Three years ago, my sister died of a heroin overdose. I hadn't spoken to her in about 3 years. It was just, like you said, conversations. It was horrible having a conversation with her. And as much as I hate text messaging, that's what a lot of our conversations were, because life sucked, everyone was out together, the game was rigged, everything, and then I get a phone call one day at work that says, I'm sorry, your sister died. And she was just turned 59 years old. And I knew she had done a lot of drugs in life. We both had, you know, kids from the 70s. We both got pretty much straightened out. I got completely abstinent from drugs and alcohol. She did not. She drank, she smoked, she partied, and I did nothing. But through some health circumstances, you know, they started giving her opioids, as well as her son, who was got hurt bad in the war in the Middle East. And some people get a jacket put on them that says, oh, you're seeking drugs, and they are. And so they just give them the drugs to make them go away. And then you can't get those prescription opioids anymore. And so you use heroin. That's how that works. And a month after she died, we finally get, you know, the death certificate, and it doesn't say pneumonia or any host of other problems. She said it said acute heroin toxicity, and the coroner's statement on there said within minutes of ingestion. And now, 3 years later, I'm thinking it was a suicide, because she knew how to do this shit. She'd been doing it for a long time. She'd seen plenty of other people die. And when I saw her at 59, she looked worse than my mom, who died of cancer at 72 and spent the last 6 months in the ICU. She just looked horrible. A year later, her son, who was 38, you know, the death certificate said sepsis from a perforated bowel. But I know for a fact opioids were involved. When my brother died 6 years ago from cirrhosis, Hep B, Hep C, and liver cancer, they're coming out from Colorado to Omaha, and they're like, don't let the hospice nurse in the house, because they're going to collect all his medication. He had so much morphine in his house to control his pain, and he was using it legitimately. His daughter was there monitoring him. But he had a lot of it, man. There was a lot of that stuff stashed in the house. And my sister was suddenly, no, we'll take care of it. We'll take care of it. Free drugs, man, and they were coming to get it. They made 3 stops at hospitals going from Denver to Omaha for stomach pain. Yeah, he had legitimate bowel issues, right? And everybody just threw drugs at him, and he kept taking them. And it killed him too. When I went out to Colorado when my sister died, she's in a really nice little suburb, kind of, you know, like Traverse City, real beautiful flowers, got the sprinklers going, lawn's really kept up. On the outside, it looked beautiful. On the inside, it was rot and decay. There was a hole punched in every door and in every wall. You know, their lives had become unraveled by this. It took me 3 days to find her wallet with her ID in it. While we were there, we got a notice from the bank the house was going into foreclosure. Her son was in jail. You know what? Because of a lot of issues, I only understood about 1 out of every 20 words in that film. I've got some hearing issues, okay? But I didn't need to hear the words because I know the story. I've lived the story. I've got friends who live the story. I see the story at work. I see people come in and their arm is like, oh, you got a bad infection there. When did this start? I just woke up with it like this. No, that's not what happened. You know, you've been injecting drugs in that arm and you've got bad abscesses. And unfortunately, the individual lost his arm. You know, life was tough, it's tougher now. I hope the guy's still alive. You know, I came here, I don't know why. My friend said, come and help. So I'm here. Thank you.
And then I asked two of the gentlemen that help a lot with homelessness around town, Ryan Hannon from Goodwill, the street outreach worker, and also Mr. McDonald from the Safe Harbor Shelter, which we're very grateful to have that new location and stable facility. So.
I'm Mike McDonald, I'm Mr. McDonald. Thank you. And I'm the chair of the board of the nonprofit that runs the Safe Harbor Shelter, and that is a volunteer position, but we provide temporary seasonal housing to those experiencing homelessness every winter. We operate from the 1st of November through the middle or latter part of April. We have seen an increase in the number of guests at our shelter over the last 2 years. A year ago, we averaged 58. This past year, we averaged 67 a night. And what we've also seen, although the people we've served over the years, even when we were a rotating shelter in churches in the early days, many of our guests, certainly not all or near all, but many of our guests do suffer from addictions, alcohol, drugs. But what we're seeing in the last 2 years is an increase in the number of guests that are suffering from drug addictions, many of it related to opioids. We're also seeing a younger group of guests, many of whom are addicted. Now, some of these folks, their addictions occurred and are maybe the cause of their experiencing homelessness, but in other cases, the addictions occurred after they experienced homelessness and they're trying to kill the pain of being homeless.
Yeah.
And I'm going to turn it over to Ryan. He works personally more closely with the folks that are actually on the street here. I get to know some of them at the shelter, but Ryan does this every day, year round. So I'm going to let him talk.
Thanks. I'm the street outreach coordinator for Goodwill Industries. I've been doing street outreach to people experiencing homelessness and sheltered in our region for about 12 years. I'm blessed now to have a team of 7 fabulous workers out there, so we have a better coverage of the 5-county area. I wanted to share a little bit about the film that we just saw. And you know, of course, it can be very hard to watch, and even for myself, very hard to watch, and found myself at tears at times. And I'm so grateful for Caroline to be here and to see her work and her perspective and coming to share with us. But she gets it. It's hard to describe what you do and have to go through out there to meet the people where they're at and witness the suffering that they're having and go into those trailers, containers, dark spaces in such what appears could be scary, but over time as you do it, you know, like the people, the level of suffering that they're in there, you're in there as a helper and somewhere to come help alleviate that suffering. I wanted to point out, well, Caroline said it best, you just, in the beginning, you just go to the people and have a conversation. And I wanted to piggyback on that and actually listen to the people. So many people in the helping field seems like they act like they don't know how to listen. If we just listen to the people, they'll tell us what we need or what they need. And building that trusted relationship takes time. But there was one nurse, Liz, I think her name was in the film, and there was the one lady on the street that was twitching all over and eventually said, you know, screw you, you know, leave me alone. But if you noticed, the client on the street was not in a good place and dropped her sweatshirt on the sidewalk. Most people would want to pick that sweatshirt up for her, and Liz did not. She allowed that client to be where she was. She wasn't trying to just come in and like do everything. She was allowing that person to have the space to be herself in that situation. So I suspect Liz probably was able to engage with that person at a later time by allowing her like to say no and to go and like it's okay and not freak out, not take it personal, and not just come swoop in and do everything. That was very interesting and really opened my eyes to what an awesome program that you have there with the street nurses. So building relationship with folks can take time, like she said, but over time as you build that trust, your reputation precedes you. So people know street nurses. When they come, they know what to expect. And out here, we don't see that level of suffering, maybe on an individual basis, but not as much all around. When that stuff happens, we see it in our community. We go into the woods, in the dark places, and we're a housing-focused team. We work to connect people to the clinics in those places, but I can share the frustration when you come alongside somebody that really needs a place for the night and there is nowhere to go, and you spend all day long just trying to find a place for somebody, even if it's for a short time. So I'm wondering, I'll start off with the first question. Caroline, did the lady who got into that motel, how did that get paid for?
Oh, right, with a lot of difficulty. You know, from country to country, I don't think there's difficulties across the board. We were working with the clinic, that was Liz, right? Liz and her mom, and Becky. And yeah, so the clinic, there was a social worker at the clinic. And because we have connections with the different SROs, the hotels, right? Well, you saw my tone of voice. I wasn't gonna hear no, right? And so that's what opened the door. It didn't open the door for Liz, who was pregnant, because you know, the front doorman and Liz had altercations before, which, you know, it's like, okay, well, whatever, right? Yeah, and I eventually got paid the next morning. So again, it's trust, right? But it's not always easy to get a place. And I think, and that's unfortunate, because that's one of the things that needs to be addressed, right?
Are there questions in the audience? Hi, thank you for being here. What strikes me in the documentary and in your conversation here
you're using the word suffering. And it strikes me that humanity's been challenged over time with ineffective and unhealthy actions to relieve suffering, and our opioid epidemic and our drug epidemic is the challenge for our time in this regard. What I struggle with as a nurse is this dynamic of what's the end goal here, and how can we truly help? It's when we're faced with an individual in front of us, we can act with empathy, we can act with kindness, we can act altruistically in this regard. From a community nursing standpoint, we get to stand back a little bit and try to figure out what our goal is here. And the goal of ending suffering, it seems like an endless human endeavor, but we're really losing right now. And I'm wondering your thoughts on how this connects as a way to relieve suffering at the same time as we're dealing with a chemical dependence here that is making this coping mechanism far more complicated than perhaps we've ever seen.
I'm going to talk for a second about that. So that would be a place to talk about some of the fundamental principles of harm reduction. And that would be that the goal in harm reduction is defined by the person themselves. And so Becky's the person who defines what Becky's goal is. Doesn't matter what I think as a social worker or as a certified addiction specialist. Doesn't matter what I think Becky should do. Becky defines the goal because Becky's the one that walks in Becky's shoes. And in fact, Becky's really the only one that knows what's going to work for Becky because none of us walk in her shoes. And so that's a real paradigm shift, right? And paradigm shifts take decades. So it's a process. Nobody comes to a training like this and walks out of here and goes, okay, great, got it. No, it's a process. You know, so there are things in here that people will react to, and other people are reacting to different scenes. But so that's a fundamental principle, though, of a harm reduction nursing association and a harm reduction program, is that the goal is defined by each individual as they need it to be.
Yeah, and I don't see it as winners and losers. And in fact, I see the health system losing if you don't change your ship. I really do. Because we don't listen. We get annoyed. We get angry. I mean, shape up, really. We're human. And in this day and age, look at the politics around us. The Amazon's on fire, Brexit. I mean, look at this shit. So wonder all of us are not on drugs. I mean, come on. So it's not a winning and losing game, it's listening. It's actually listening. And for sure with Becky and Liz, you know, I lost my shit with them right halfway through the movie. That took 8 hours, actually. 45 minutes, it's like boom and nothing, right? That took 8 hours, and I was losing my shit. I go, you know what, I'm gonna absolutely tan your ass here if you don't get back in that goddamn van right now. You know, but I could talk to them like that because, you know, I've created a relationship over time, and, you know, and that's the winning. That is the winning, if you want to put it in winning and losing. And I just think it's bringing humanity, is listening. 90% of my job's listening. You don't get a pat on the back for listening, do you? Anyone in health here? It's quantitative. How many people do we test? How many HIV? How many Hep C? Fuck that shit. You've gotta get down to the humanness. You've got to get down to the humanness, and you've got to reflect. Every health professional has to reflect as to what their attitudes are to the person in front of them. That is the key, because we've got to unwrap that stigma, because stigma kills. There's no quantitative data there, right? There's only data on Hep C and HIV that kills. There's no quantitative data on stigma. There's qualitative, but we don't really listen to qualitative, right? But this is a relational game, if you want. And I'm on equal footing with that person. Now, for sure, I'm going to encourage them to, you know, do you want to stay doing drugs right now? What do you want to do, right? Because I see you every week. If you want to give it up, what do you want to do, right? And I will have conversations, and I had conversations with the woman on the cover of Bedlam. You know, one day she wanted me to test her, and she was just completely wired on cocaine, and I looked her in the eyes and I go, honey, no. There's no consent here. I'm not going to test you. If you're HIV positive now, and then you've not understood what I've asked you and what I've talked to you about, no, I'm not going to do that. And it's okay to say no, right? But you've got to, I can't, the relationship, right? And it's not, I don't think I failed at the end of the day. It's like parenting sometimes, when you have 3 kids and none of them will listen to you. It's is that winning or losing? It's life, right? It's life and negotiation. And yeah, I don't know. Can you add to that?
Yes, I'd like to touch on that too. So the street outreach program I work in is a housing-focused street outreach program. We work, we have those conversations, we'll get people connected to treatment, detox, clinics, whatever it is, but our main focus is to help them get housing. Out of 12 years of doing this, none of the clients I've worked with ever got sober or mentally well while homeless. They may have tried several times, gone to detox, gone to treatment, and they go back homeless. It's a matter of time, and it's a very short time, and they're using again. And they're not using for fun or pleasure. It's stay warm, alleviate suffering, cover up the trauma they have had in their past, and possibly currently having while experiencing homelessness. So what I tell my staff all the time, and what I learned early on, is I have to be out there. We watch people suffer all the time, but we have to be able to work within that. The end goal is housing. Some people are ambivalent. Nobody wants to be on the street. They may not want what we're trying to offer them. So it's our job to work within that, to help find the way that's going to help get them connected. And if you think of the woman and her pregnant daughter in the shape they were in, you can't connect in your brain how those people are going to get into their own place to live. It takes a long time, and a lot of it even is loving them, being there for them enough till they realize they're worthy of the help, want to engage in the help, and then believe that the help's going to come, and then help keeping them engaged until that actually happens.
This question is for Caroline. In the movie, you're testing a street person for various STDs, and it got me kind of curious. 3 quick questions. How do you identify that person? Is it like John on 8th Street, or do you know their full name, or what do you record? How do you get the results back to them if you don't even know the next time you're going to see them? And thirdly, what do you do about the results? What are the options?
Oh, there's lots. Because guess what? We're the BC Centre for Disease Control. We're going to hound you down because it's a reportable disease, right? So yeah, it was one of those questions. And we battled this question, even the street nurse team. Well, you can't test people and then they won't come for results. Well, of course you can test them, right? So again, it's creating that relationship. You will see them, or somebody will see them, right? Through the social network. So it's a lot of social networking that we do. And, I will ask somebody who asks somebody, right? Well, hey, and I'll do it globally. I won't do, Karen Jones, tell me where she is, because everybody knows what we do, right? So you've got to look at confidentiality and everything like that. But we were very successful at finding people and giving their results back, and they knew where to find us. So that's when you have a team out there in different places, and we're crisscrossing the large majority of people, and we're also working with agencies as well. And it worked. And believe you me, most people want to come back for their results. You know, you may not think, but it may be a while, right? But most people want to come back for their results. I think better than I do. I never want to go back for my results. Do you guys want to go back for yours?
All right, hi. First, an observation and then a question for you. The observation just regarding the housing thing and how, you know, getting people into housing is key. But in the U.S., or at least in Michigan, as far as I know, all of the things that we have in place for getting people into housing, they come with the requirement that they cannot be using any drugs. And I feel like that ends up being a rather big barrier. And so I wonder if there's been consideration of how we might go about not necessarily having that as a requirement. That's just one thing to contemplate, I guess, if you're in that realm of work. And then the other, as the question, I do have a little follow-up, but the question, Caroline, would be, I'm wondering your impression of, based on what you've heard throughout where you've been in Michigan, what you're feeling with where we're headed and what the conversation's been like. I just moved north, and Pam, I've emailed with you a couple of times, but I've just moved north from Grand Rapids, and I worked at a methadone clinic there, and we had 3 people that drove down from Traverse City and from the Cadillac area to come down to get their medication. And I know there's a clinic in Gaylord, but when you've got people talk up medication-assisted treatment, but then methadone's not accessible to anyone unless they have a vehicle, unless they have, and if they happen to get kicked out of a Medicaid-funded clinic, then they're stuck paying $84 out of pocket because a lot of insurance, or a lot of clinics don't take insurance either. So that to me makes me feel like it feels so daunting and so a human rights issue as well. This is not right that people are not able to necessarily, if they're ready for treatment, get into the treatment that would help them most. Or as harm reduction, I had tons of guys that were still using heroin and also coming to the clinic and holding down amazing jobs and being there for the people around them. And I just wonder if you can help me see some hope, I guess.
That was a lot. Thank you. I'll touch on the housing really quick first and then hand it over to Caroline for the rest. The response to homelessness has changed. We actually, all across the country, the standard is called Housing First, where we help people get into housing first, no matter if they're using, no matter what they're using, whatever it is, and then help them work on the issues to help stop using or harm reduction or reduce whatever that looks like. It's no longer a requirement to be sober or smiling or nice or morally straight, right, to get into housing. And I'm really proud that our community over the past about 5 years has really bought in and turned the way we respond to homelessness upside down, just like across the country. And there's still a lot of communities struggling. We have a long way to go, but our processes, our policies, we prioritize. There's not enough help to go around to help people who are homeless to get into housing. And we actually use evidence-based tools that ranks the most likely to die next on the street. And then as a community, as the homeless response system, we work to house those people first. So we've reduced barriers at the Goodwill Inn. The Goodwill Inn used to be 0 tolerance. I don't know if you picked up on the movie. In one of the shelters, they were trying to get that lady in, said 0 tolerance. Is that okay with you? That means you can't be under the influence. You can be under the influence now at the Goodwill Inn. You can't actively use in the building on the property while you're there, but you could literally use or drink across the street and come in. And that is a huge shift. Yeah. Safe Harbor is the same way. And that is what we call meeting people where they're at. And so we use that approach in street outreach. We've been using that approach in street outreach since I've been doing this since 2007. And the rest of the system is now caught up. Now the biggest challenge we face is actual housing units to help people get into. So we actually have some subsidy dollars that come to our community to help end homelessness for folks that goes unspent because we can't find units to put people in that price range. There's a lot of work being done regionally, locally, to help address that issue. So you don't remember anything tonight, remember this. Housing ends homelessness, and any chance you get to talk to people to help promote housing really helps. Our system is right, the right way to get people into housing, we just need that housing, so. Then Caroline, I think the question was how are we as a state doing on this? Responding to, yes, personal.
Well, I think I was talking to Pam. When I'm invited to go to different places, it's not about me telling you what to do. It's like that on a one-on-one basis too. I can't tell the person in front of me what you should do unless they're nearly dying, and I say, you know what, you're going here. So I think I'll tell you what we have in Vancouver, right? And unfortunately, we've been battling with this issue, as many of you may know or not. The downtown east side is home to 18,000 people, of which half have been addicted to polydrug use. We have our first safe injection site, and we've had it now for 15 years. Due to the fentanyl overdose, we have overdose prevention sites. They're every other block for about 6 blocks. The crisis is not only in the downtown Vancouver, but it's outside in the suburbs, it's all across Canada. Now, Vancouver is very far ahead, right? It's on the scale of moving and being leaders, we are, except for Europe, right, who are obviously have done all this. We started needle exchange back in the early 80s. Now, the thing that we did, which could have, and I would say, and I think data shows that influences HIV transmission, spiked our rates, were that we did a punitive thing where, I'll only give you 1 needle if you give me 1 back, right? 1 for 1, that's bullshit, because, as we know from drug use, you need more than 1 needle. And the street nurses never adhered to that. We said, you know what, how many boxes do you need? Because come on, if you're using every 3 or 4 hours, you need more than 1 needle. And then you lose needles, and it's just common sense. So it started there, and that was 20, 30 years ago with needle exchange. And it's in all the health authorities. It's in non-profit organizations. Naloxone is swamped the whole city, especially the downtown east side. Everybody's practically trained. We have alternatives to heroin, Cadian, Suboxone. There's heroin trials, there's hydromorphone trials. It's happening in non-profit organizations. It's happening with St. Paul's Hospital. St. Paul's Hospital is a Catholic Catholic organization, in the West End, and they've changed, they've put special programs in the hospital to bypass a merge, so if people come in who is a user of drugs, they go through, unless they're dying and need resuscitation, etc., they go through a program called RAC. And RAC is quite different, and their language is very much looking for the psychosocial, emotional trauma versus the physical. So normal emerge for physical trauma. For the emotional trauma, you go to another emerge, right? So that takes the load off emerge, because I think that's where when you're talking, I think the first person talking about a winning and losing game, right? Emerge is fraught with high anxiety, and so to take the stress off the emerge people and go through RAC, and then they have medical floors, and then there's an overdose prevention site outside the hospital now, so that people go there and use. They're not using in the hospital, and they're not overdosing on the units on the hospital, right? So there's a vast array from needle exchange to treatment and IOTs and clinical trials and supervised injection sites and safe injection sites. That may all change because we're going to the polls in October. And hopefully a conservative government doesn't come in. Harper tried to get rid of the safe injection site twice, and he did not succeed. So the impetus in Canada is, especially British Columbia, you have the mayor on board, you have the province on board, you have the provincial government on board, and it's all harm reduction. Yeah.
Hi, I just want to thank you all for being here and everything that you do. I am in recovery myself, and I know Ryan. You probably don't remember me, but I used to work with you at Safe Harbor 10 years ago, and I also have been homeless a couple times in my life, and what you touched on. With being, you said, going to the people where they're at and letting them feel worthy enough until they feel worthy enough that they are worthy of what you're doing for them. You know, that in itself, right there, just the fact that on my side, like, when I was in my active addiction, I literally felt like how, was it Becky in the movie? Yeah. And she said that the hospitals literally think that I'm there for the drugs. And that wasn't the case for me either. But they do feel that way. They just automatically label you, and it's hard. So you don't want to go to the hospitals. You feel like you can't go anywhere for help. And so when someone actually listens to you, who is in the medical field and goes to you on a basic human level, that means more than anything. Because they look at you like you are a human being and not just somebody that's just going into it just for drugs, like just a label, like just get her in or just give her more drugs, or because we really just want someone to listen to us. We do want help. We don't want to live like that. And I cannot thank you enough for what you do, because it is truly the person who is using who has to make the decision to want to get help. And it's gonna, and it may take 10 times to go to rehab or whatever it is, but when you finally get it, and when you finally get, to a spiritually fit level, an emotionally fit level, physically fit, and it takes a long time to get there, and I'm never gonna stop learning about myself. I mean, I'm starting all the way over again, I'll have 8 months coming up, but, I don't know where I'm going with this, but my point is that I thank you very much for what you do. It means, it's to no end. I can't even explain how much it means. But my question is, I don't have any letters behind my name. I'm not a nurse. I don't, you know what I mean? But I do want to give back, and what can I do as a basic human person to help other people that I don't have, when I don't have a nursing degree or anything like that?
No one needs a degree, that's a disease. That's a disease. Life is a degree, isn't it? What I think you do amazingly well is just tell your story and keep telling it. What's happening in Vancouver is more and more acknowledgement that people who use drugs are the ones that are experienced, and they're more experienced than health. They will always, anyone with their disease will be more experienced than health. What health is good at is cure and fix. And that's partially what's got us into this problem, is the cure and fix, right? And so I think that when we're looking at pain control, when we're looking at comfort, we've got to open the doors to alternative health as well. And although the healthcare system, don't get me wrong, does a fantastic job. It is not the only gig in town, but there's a lot of emphasis and a lot of pressure on the healthcare system to cure and fix it. You know, they're not really in the role of harm reduction unless you're in public health, and then you're in prevention, then you're in harm reduction. But I think if health can allow people like you and you to get on to tables and be part of decision making moving forward, because that's the only way things have ever changed. If you look at the HIV movement, people with HIV marched up against health and said, you know what, you got to do this, you got to change things, you got to do things differently. And that's what people who use drugs and people in the sex work are doing to health right now. It's not fast enough, and that's why we made Bedlam, because we want to get that in every nursing school, because the next generation needs to know that, you know what, you're stigmatized, we're all stigmatized, and we got to unwrap that and be where that person is. And, you know, understanding that the person in front of us is the one that's got to do the work, but we got to hold your hand, you know? And we've got to work together to guide people through that. But yeah, your voice, everybody's voice, I don't care. You don't need a degree, a master's, PhD. No letters behind your name, no. I think people without letters behind their name have more common sense than people with letters behind their name. I don't know. Yeah, anyways, thank you for your comments.
Thanks for coming, and whoever set this up, appreciate it. This is a good opportunity. My question is, through the film and in this panel, I've noticed like a recurring theme of therapeutic relationships, and how you got to that point is my fascination. How did you take that leap and like jumping in the deep end and going out like behind a fifth wheel and getting people out of like the streets, helping them? How did you get to that point? Because as someone who's just going to step out into the field, that's a little intimidating. So I'm just wondering what strategies did you learn over the years of doing this that could help, you know, younger people going into it?
Never do things on your own. Make sure your team's behind you. Well, you just got to do it, right? You know, I mean, it's a human thing, and always your standards of practice here and all that stuff, the CRNABC, the BCNPP, and you know, God, you'll get into trouble, whatever. Well, no, I won't get into trouble. I've got standards right there that say I can do the nursing, I can do everything except inject somebody with a drug, right? I can do everything. And, you know, I can watch them do it. If you overdose, I can do that, right? So I can do everything. I can go behind a truck, I can do that. I mean, of course, there's safety, will the truck fall or whatever, but, you know, I think nurses, any country, have that same standard and policies around harm reduction. I'm not sure actually about harm reduction, but definitely where we were. And you've got to find the right team. I mean, the team we had was very unique. There's 2 other teams in Alberta, and there's small little pockets of nurses. What's happening in across Canada is that peers and social workers are maybe moving into the domain of nursing. I think that you should always have a nurse as part of your team, and it's a team, nurse, social work, peer, and everybody comes with different experiences. So yeah, I think that you find a team, the philosophy, and you know, there was 12 of us on that team, and we all had issues, we all came in, and why did we connect with people who use drugs, right? We were marginalized within the healthcare system ourselves, right? Because, you know, some of us may have had experience with drugs, right? Or alcohol, or some trauma, or something, or had stigma against us from the healthcare system, so we could understand, right? And once you connect to people who work like you, and St. Paul's Hospital is another classic example, it's a core group of nurses there that will do anything with the patients within their scopes, obviously, and doctors, and once you find those passionate people, then the vehicle moves. But you are fighting the healthcare system, right? And you're fighting a lot of people around you, but the core in essence is that ethically and morally, we have a duty anywhere in this world, I think, in all the policies to deliver care to people. That's the business we're in. That's the business we're in, right? So if race, judgment, religion, etc., gets in the way of that, I think you can argue that, right? Because it's against policy. But yeah, you find the niche and find the people, and also it's funding, right? People in non-profits and organizations are going to make positions for people if they see the need. But yeah, it's finding a group of people.
So I'll speak to a little bit of that as well. The program I'm in is literally street outreach, so we have like a venue, if you will, to be able to go out and to do it, and then the courage, I guess, the motto, I go back to and thank you for Colin Kaepernick for bringing this back to the mainstream, is just do it, like Nike. Like literally go and talk and listen to people. And one of the kind of criterias, and I don't know if this is a teachable thing or not, but the really unjudgment aspect of it, connecting with somebody, there's a lot of stuff that I can't do for people. We will do everything in our scope to help, but there's stuff that we can't do for people, and we build trust by not promising things we can't do, doing what we say we can, even if it's nothing at the time. And people respect that, and they recognize you as a helper, and it really is safe. 12 years I was doing this, I've never been in a compromised situation. There's certain safety precautions you take, right? Be aware of your surroundings. There's always a trail, there's always a way out, but those are kind of second nature type stuff you develop over time. But if there's really I'm a professional and I have a platform of street outreach worker to be able to do that, and that really, really helps. It's not just like randomly going out to the woods or the under the bridges just because, right? We're targeted, we're going to be with the person, the angle is housing, and we talk about person-centered. People, it may appear that they don't want housing, but they actually do. So in street outreach, we run interference into people's lives, use motivational interviewing to help them to get to the spot where we can work on housing, because nobody wants to be out there on the street. They may not want to go home where the abuse is. They might not want to go to the homeless shelter where, now we have a low barrier, but you can't use while you're there, or there's theft, or, I mean, we have some nice homeless shelters here, but no matter how nice they are, living in a homeless shelter is crappy, right? And so if you refuse to go to the shelter for probably a good reason, you still should have services and someone to try to help you get into housing. So it's really doing it, having a safety plan, and really just being with people. We all have our issues, we all have our flaws, right? So we recognize the stuff that we're seeing that looks like anger, pushing away, laziness, choice, really are effects of trauma that they have had in their lives and what they're dealing with. It may take every ounce of kind of will someone has to come approach you for help, and recognizing that, and to be able to listen and deal with people where they are with what they're dealing with.
I wanted to add one thing here, and we've certainly heard from Ryan and that, who are experts at dealing with people experiencing homelessness, particularly those that are addicted in some way. But you could have walked in here tonight and listened to this and assumed that everybody that's experiencing homelessness and is staying in places like Safe Harbor is an addict of some sort. That is not true, and I want to dispel it because we have a significant percentage of our guests who are sober. They have jobs that they go to every day. Their problem is that if you work minimum wage in this town, you don't earn enough money to have a place to live. Renting a studio or one-bedroom apartment costs a minimum of $800 to $1,000 if you can find one. And you think minimum wage, that's over half of a person's income, net income for a month, well over half. So, you know, certainly addiction is a serious problem that we need to deal with, but there are other underlying problems that are causing homelessness in the Traverse City area and other parts of the country that could be solved in other ways. You know, with providing fair wages for people and providing affordable housing.
So I have a comment and a question. The comment was how powerful your movie was, because at first it was kind of like that judgment stigma. I was thinking to myself, why is she giving needles to these people? We should be trying to avoid the drugs, and we should be helping them. But then towards the end of the movie, I started realizing that you were thinking, they're going to do it anyway. I'm going to give them a clean supplies and prevent the HIV, which I think is amazing. My one question though, we have a lot of nursing students here, and as a young person and as a young nurse going into a new profession, and since you're a professor, I was wondering if you could give some advice to like the younger generation. We've had a lot of 18-year-old, I mean, it's all across the board as far as age, but we've had a lot of 18, 19, 20-year-olds who've died from this. And sometimes I feel like it's easier to connect with, the older population. Not always. I've connected with people my age too or younger, but how going into this new profession should we approach this?
Well, you need to shake that box. That's what you need to do. You need to go in there and just shake it up, right? Don't do it on your own, okay? It's a hard place to be. The medical system or the healthcare system has changed drastically over the last 40 years. It's a business. It's task orientated. There are students that are in my classroom that they go and do clinicals and they won't have had a conversation with the person for 12 hours because they're giving out medication after medication after medication. Advice, I mean, it's a great profession. It's a great system, as I said, in many ways. I think that you will learn a lot from the people in front of you. And, I think, and I'm glad to hear that, your opinion of needles may have changed because many people think it's enabling, and I think it's actually giving people a lifeline, because any one of us in this room could start tomorrow or are using drugs, injecting drugs, and a clean needle will prevent you from getting Hep C and HIV. And when you're ready to give up and move into recovery, etc., then you have a much better chance, right? And that's our profession, that's where we are. And I think that, even though it's a task-orientated system, there's still, when you're having and doing tasks, you can still connect with that person. And this DVD is loaded with little tips, and I hope, I've got loads of them for free now, but they're all back in Canada, because this is on the National Film Board site. It's broadcast everywhere. And there's a teaching manual as well. There's little clips there that really talk about the fact that, especially in addiction, if we can kind of turn it around, we think that people using drugs, it's a problem. Well, it's not a problem necessarily for most people. Some people, it's a solution, right? It's a solution. So we've got to reframe, and also vulnerable people. I don't think anyone's vulnerable out there. The people that I've seen over the many, many years, they're trying to survive, and are very powerful survivors. And so we have to reframe our language, and you have to meet the person where they're at and be very open, right? And it's constant reflection in here, constant reflection. Because I think what the healthcare system does to us is they want us to be perfect. We're not perfect. You know, there's a whole bunch of information in the DVD too. There's healthcare professionals that are addicted, right? And they've gone and had help through their unions and their way, you know, and they're there and they're working and they're connecting. And I would say that, you know, if a couple of leaders in our world would have had some addiction issues, they would have had more compassion humanly to people, you know. So yeah, I think it's get in there, right? Go for it, and really learn from the person in front of you, because they're the ones that will teach you the most.
I also had asked Kelly if he would please respond, because Kelly's a nurse who's working as a nurse, and he works here in Michigan, and so I think Kelly might have some feedback on that too.
When I lived in Colorado, excuse me, when I first got my LPN in 1992, I got a job in an indigent care clinic. And this was for people who weren't poor enough to get state aid, Medicare, Medicaid, but made too much money, but they couldn't afford insurance. Right? There's that middle ground. And I am a very white boy from the suburbs. And I'm working at this clinic way on the other side of town, where we have people from all ethnicities, all kind of different backgrounds, addiction issues, sex worker issues, homelessness issues. And what I learned was just folks. It's just us. It is just us. You know, a couple years at that clinic, I moved to the clinic that was 2 miles from my very white neighborhood. And these kids who would come in, I would see them at school functions where my kids were going to school. And their parents and their family members. And it's like, hey, here we are. Because we're part of a community. And they will teach you. You know, this idea of meeting them where they are, okay? When I got clean and sober, it's like, a place to live where you can still drink? No, man, they ain't never gonna get sober. You're enabling them. Those people are gonna die. No, I've changed my mind on that. You know, clean needles. They're just gonna shoot up more. They're gonna shoot up anyway. You know, this at least gives them a chance, you know, to avoid some of that harm and some of the complications until they get where they need to be, where they're gonna get clean and sober. Yeah, drugs and alcohol are the solution, not the problem. I had a lot of problems when I started drinking and using. And then that became the biggest problem at all in my life. You know, drugs and alcohol was pouring gasoline on a fire. I had to put that initial fire out and stop pouring gas on it. In healthcare, you're gonna see everybody and everyone from every walk of life. And it's just folks, they're just people. They're like you, they are like me. It's one-on-one, it's us. You're looking at yourself in the mirror. Those are gonna be your patients. Those are the people you're gonna take care of. Especially here in this town. Everybody knows everybody. Everybody's got some kind of connection, you know? And in a lot of ways, that's really cool because you really feel connected as a caregiver in this community. Hey, I know this lady, she's a breeder of mine. You know, this is the guy that works on my car. This is the child of the guy that works on my car. You know, it's community.
And I would just throw in that, you know, in listening to Caroline and thinking about my own process through the years, you know, you got to be open to what people are telling you, and you're going to get your feelings hurt. You know, you're going to be offended, and good, because that's how we learn. And some of the most meaningful things I've ever heard. I remember being at an HIV meeting in Detroit, and I was running an HIV section of a Latino agency there. And so we're at this city meeting where there's lots of people from across the Detroit area, and this woman looks at me and she said, "Excuse me, but how do you know, all you white people think you're smarter than everybody else and you think you're better educated than everybody else. So how do you think that you from Traverse City are going to come to a meeting for HIV in Detroit and tell us what we think is going to work best in this town?" And I was like, you know, I was hurt. It was offensive to me, but she was 100% right. You know, if I would have gotten angry and marched out of there and gone, "Oh, to hell with that woman, I'm not coming back here, I'm not coming to those meetings," or okay, I'll come back to this meeting, but I'm not dealing with that woman, or whatever, that kind of an action or a reaction in my head, you know, to this day, I remember her because she taught me something very valuable that I think this town needs a lot more of, right? So I'm grateful, and yeah, sounds like it. But anyway, so you know, you got to be open to that stuff, because these people are going to tell you if you're, you know, they'll call you to the carpet. And in fact, I think that's really what I value about doing a lot of this work, is that, you know, it's a privilege, because it keeps things in perspective, makes me grateful on a daily basis, and it's taught me a lot about myself that I needed to learn about myself.
Hi. So throughout the film, you consistently gave everybody that you worked with the opportunity to make their own choices. Is there a point where, as a healthcare professional, a licensed healthcare professional, you are a defining line where you have to actually take action against their wishes? And if so, are you protected against whatever happens beyond that?
Yeah, there is times when I have to kind of not go with the flow, as it were. Yeah, and that's the majority of time with these mental health issues, if they're going to harm themselves or they're going to harm others, right? And that's one clear kind of example. Yeah, I don't always do what people tell me I should do, because I don't think it's in their best interest, and I will have a discussion and tell them that. Like the one that I was talking about that wanted me to test them, right? And she was completely out on crack, right, and not in the best place. And you've got to say no. And yeah, and my standards will protect me. Yeah.
Okay, right here.
Yeah, my name's David Bess. I'm a family physician. I also do mostly addiction medicine now and hospice medicine. And I really enjoyed the example or the cases that you went through here in the movie. And I remarked, or to myself, I was thinking, these are a lot of like hospice patients. Their prognosis in some cases is so poor, and you still have to work with them and try to make things the best you can. You know, in some ways, we make this too complicated when we're talking about addiction. I think we have to start looking at it as a chronic illness, just like heart disease or diabetes. You don't say, well, you can only have these treatments if you do things I want you to do. We don't do that in heart disease or diabetes. You give them the best treatment they can get. And I just also want to make a comment about the woman, I don't know what her name, the mother, what was her name? Becky. So there's a term, it's called the Lazarus-like effect, and I don't know if you guys could comment on that, where it's basically when someone gets in treatment for opioid use disorder with either buprenorphine or methadone maintenance treatment, there's the term Lazarus-like, they're reborn. And I could see that in that woman where she looked 10 years younger, was very happy, and looked like she had hope. And I mentioned methadone and buprenorphine here because I think in this case she said she was on methadone. I think that was mentioned there. So that just gives you an excellent example of the night and day that you can see when you actually give someone the standard of care treatment. So again, I'd like to compliment on those great examples. And one question would be, how do you deal with dealing day in and day out with people at such poor prognosis? I mean, you'll have some success stories, but it's got to be exhausting. And maybe you have some strategies that you can help us understand on that. Thank you.
Well, the day-to-day stuff, for sure, we worked in pairs and sometimes in threes, and then we switched up between clinics and outreach and went to the jail system. For me, it was the stories I was hearing that would get inside my head, right? And there was a lot of time for us spent debriefing about that, and in meetings that we specifically set up for that. So that was all in place. We had the turnover on the team was very low because we had a supportive boss and bosses. And they understood where we were and what we were doing and the care we required. So that was, and taking care of each other outside of work as well, goes back to that tight-knit team that I was talking about, and finding your niche with some people who really understand, right? Because I think that, many people in the healthcare system does not understand how to take care of the population. And also methadone, all these treatments that we have and had over the years are lifelines for people. And I think it's not for us to decide which one they go on, it's for the person in front of us again to decide which one is good for them and what works. And but what I see that it has done, and research shows, is that the person who is working in the sex trade and also addicted to heroin, if they go on to an IOT or methadone or whatever alternative, is that they're not chasing the drug, and they're not drug sick, and they're not going out on the street and making themselves vulnerable. Because what we see is that, a woman can be on the street corner, and then, after a Vancouver Canucks game, there's 4 guys that are in a car, and well, guess what? She goes in the car. And she's drug sick, right? And she needs the money. So when you have alternative treatments out there that are available, that stops that cycle, and then she doesn't end up in emerge, and she hasn't got a broken jaw and everything else, and it's more expensive for the system, and there's less self-esteem, or a dumpster or dead. So all this is harm reduction, and I can't remember, was there another question?
You said coping strategies, having a good team,
yeah,
and then the term Lazarus-like effect.
Yeah.
I wonder if that's ever come up in your discussions.
Not really.
Okay.
We're not really, or we weren't, because there's only, the team is smaller now. No. We do the things we do, and there is a parallel with palliative care, because I think the healthcare system has shown disrespect towards palliative care as it's shown towards people who use drugs. And people in palliative care can be marginalized as well around the care they try and give to people at end of life. We saw success. We saw success and we saw failure. But then, what's a measurement of success? I remember myself working in, a sex trade drop-in center, and a woman came in to me one day, and I'd see her every week, and she would say, "Caroline, I've only been raped twice this week," and I go, and it's all in my head, right? I just all up here thinking, that's bad, right? Even once for me is bad. But this woman would have been raped 10, 15 times a week, and that would have been the standard. And the trauma from that, and the hurt, and everything else. And so the connection she made through the drop-in center, and through the nurses and the doctors and the social workers, that was getting less and less, and the education and the meeting the person where they're at and the safe needles, right? You can only go up, you know, only go up. Oh, right. There's a clip in the movie, and there's a community nurse, and she was doing a lot of education. It was quite a right-wing community, and one of her kids, in the audience there was a mother, and one of her kids was addicted, and she would never ever have thought that what would have come out of her mind was that, you know, give my son a clean needle, and now I know at least he'll come home, right? Because without needles, without clean needles, he could have had HIV or Hep C or died. And she said, I thought I would never have ever have said that, but please give him a clean needle, right? And so if you give people clean needles, if you give them an alternative to the drugs out there, and there's movements in Canada right now are calling for a clean drug supply. Let's acknowledge people use drugs in our society. They've done so for years. It's not going to stop. Fentanyl's not the end of the line. The chemists out there already are making different mixes. Give people clean drugs. Give people clean drugs, and then at least they know what they have. When we go buy alcohol, it's clean, right? Yeah. It's not some mixture we don't know. And I think there's more problems in healthcare with people who are alcoholics versus injection drug use sometimes, right? Definitely right up there. So clean drugs, there's also conversation about regulating drugs. You go to a place for drugs, and it's like getting alcohol, you have to show your ID, etc., etc. And there's even talk about hydromorphone in a pop machine that you can get at the corner of a street. So there's many different options coming for that person that needs a clean supply, right? They're not ready for anything other than a clean supply, and maybe after clean supply, then they'll go to something else, being ready, but you can't change. If we feel that in healthcare we can change people, we can't change people, right? We meet them there, and yes, we do the best around them to keep them safe, and intervene when it's a crisis moment, etc. And it does a magnificent, you know, the healthcare system does amazing in that respect. But in harm reduction, we still have a long way to go.
Hi. I am a hairdresser, that's what I do. But what I am is a social worker, and I'm in a program now for that. When I appreciate that you're doing the needles and the healthcare side of things. When I watch the movie, something I also see are the mom and daughter whose hair is dyed, and the beautiful human being in the van with the penicillin in the bum, beautiful wig and sequin dress. To me, there has to be a connection between the beauty industry and outreach. And I wonder if you've seen anything like that, or any way for us who are not nurses, but who understand that the most important thing is that connection, where we see past what that person's life situation is right now, and we can see the spirit behind that. So I wonder, and also because that industry is such a, it's billions of dollars. And so to have the 5-star beauty salons, and then, you know, homeless or poor people who are still like dyeing their hair and getting their nails done, that to me is bullshit. There's a huge gap, and a way that we can love on each other is to, I don't know, there's something in beauty. It's not maybe gonna save their physical life, but do you see any bridge there? And even if maybe it's just shampoo and conditioner, you know, regular hygiene sorts of things.
there's something called Beauty Night in Wish, and that's where the women in the sex work go every evening. And there's a bunch of beauticians that go in, and they do makeup, and they do hair, and they do all that. Yeah, is that what you're talking about? Yeah, yeah. Yeah, they have it in New York City too. So please, 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 you know, set it up and go out there and you know, yeah, because people want to look good, right? And this is the thing about stigma too, right? I mean, I'm Caroline first. I'm not a nurse, and I'm not a teacher, and I'm not, you know, well, I am, but, you know, so I'm a person first before I work in the sex trade and before I use drugs. Well, I'm Caroline first before I'm a person who uses drugs, before I'm in the sex trade. And Caroline would like to have her hair done, her nails done, her teeth done, her everything, you know? We just, it's the basic needs, right? So if you can do that, and all nursing students, if you can kind of do anything with hair or anything that's not health, but it's all health. It is all health. Everything we do is health. So we need the hairdressers, we need the beauticians, we need to make it as compassionate as possible. And if I would have had a beautician coming down the alleys with me, God damn it, yes. If I, a massage therapist, right, in fact I have more counseling with my hairdresser than anything else, actually, right? So yeah, and there was hairdressers all the time out at events in Vancouver. So yeah, the whole community has gotten out. Yeah, yeah. So I mean, the homeless shelters, I'm sure would love to have a hairdresser or something. You know, it's or a beautician or alternative. Yeah, yeah. It takes away from the problem, right? And I used to have a soccer ball in my bag that I used to carry, and we used to walk through the parks, and I would get it out, right? And, you know, some people I couldn't connect with, but when you got that soccer ball out there, oh God. And then they know that you can actually play football or something like that, right? And then people would come up to me after and they go, Caroline, you know what, I think I got gonorrhea. I said, okay, you would have never told me that if I hadn't got that goddamn ball out with you. So, you know, just normalize it. People are human. We're human. And it's not they, it's us. We're all, and have been, and could be inches away from